to move. Okay, right. So today, you can still see the screen, right?
Going.
Okay, okay. So the objectives. Okay, so the objectives of the talk today basically is to have an overview of the current trends, the clinical features, management and outcomes pertaining to pediatric COVID. We will also touch upon special situations, Missy, high-risk groups, pregnancy and breastfeeding, and then really talk about in general, how can we end this pandemic? And then lastly, we'll finish with general measures that we need to follow and a few words about vaccination. I do not have any financial disclosures to mention. There's no conflict of interest. The contents of this presentation do not reflect Mayo Clinic policies or recommendations in any way. And most of the information which are presented today are current as of today. So to really understand the pandemic, we need to know about the history of coronaviruses. So we have 4 human coronaviruses in circulation. So they are seasonal in nature, meaning that during fall or winter, they have children can actually present with a brief history of nasal congestion, cold, cough, fever. Most of them are asymptomatic and they recover from these cold infections. They can have multiple colds within that one particular season. Most of the kids, as I mentioned, are asymptomatic, but they can become symptomatic when they have a co-infection, the usual offenders being rhinoenterovirus, respiratory syncytial viruses, influenza viruses, and other common viruses. So coronaviruses are basically common cold viruses. These coronaviruses are extremely notorious because they are RNA viruses. They mutate like crazy and then they recombine. So why we call it it's a novel virus, because when it mutates and when the transmission happens from zoonotic animals and birds to human, that's when we have this novel infections, because we are not used to or exposed to these infections and the system is not prepared. So 2 of that had happened earlier. So the first was, like the SARS-CoV, which appeared in China in 2002, the reservoirs being bat. Again, in this, most of the children were asymptomatic and then did not have a major impact in children. And the second one was the MERS-CoV, which again appeared in, in 2012, the likeliest reservoir being camel. Again, children were mostly protected from this. And the current COVID-19 is severe acute respiratory syndrome, CoV-2. So this, now we are seeing, the pandemic, which is causing ravage globally. But when you look at children, the majority of children seem to be relatively well protected during this pandemic. And we will go into the details of that sooner. So the pediatric COVID, as I mentioned, forms a very small proportion when compared to adults. Nevertheless, it is important, but when compared to adults, it's, low. The American Academy of Pediatrics thinks that, this actually the rates of infection which are reported is an underestimate, because most of the children are asymptomatic or have mild illness and may not get tested. That could be one reason. And nearly globally, 3.6 million children have been infected so far. In the US, as of mid-June, the infection rate is around 10 to 14%, 10 to 14% in children among all of COVID cases. So children of all ages can be affected with SARS-CoV-2, from neonates to adolescents, and we have literature to back this fact. So when we separate children, so when we say children usually we say from 0 to 20 years, and even when we divide this group into less than 5 years and over 5 years, we see that the younger the child is, the more protected or less severe or more asymptomatic these kids are. There could be a few reasons for this. One, young children are mostly homebound. That means they are less likely to have an infection other than from a household contact. And the second, as I mentioned, probably they also have some innate innate or adaptive immunity because they are exposed to this circulating human coronaviruses. That's, like one reason why we think in the 0 to 5 year or less than 5 year age group, the infection rate seems to be less than 2%. And the majority of the pediatric infection is formed by, like children above 5 years of age. And the hospitalizations, when compared to adults, seems to be low, and it remains low. And mortality also seems to be way less when compared to adults, around, like 1%, less than 1%. So having said that, we all know that asymptomatic transmission still forms a major reason for, like the continuing spread of virus in the community, and also, like in all this the big gatherings. So the one thing which is unknown is how efficiently the children can transmit the virus, or do they really transmit the virus, and how efficiently, because we think most of the children are asymptomatic. Their viral load is much less compared to adults. And then the burden of infection in children is actually difficult to quantify globally, because like testing standards are not uniform, and not all countries have resources for testing children who are asymptomatic or like with mild illness. So this is just, like a picture which shows, like the different states within the United States, which reports the hospitalization rates in the US. And this is from the American Academy of Pediatrics. And if you look at the far right of the hospitalization rate, you can see it roughly stays around 1% or less than 1%. That's the hospitalization rates in children in the United States from 0 to 19 years of age. So far, I mean, we are 1 year into this pandemic, we know that children relatively seemed, like safe. But then we recently saw a worrying trend when we actually had 204 adolescents who were admitted. So after a peak in the hospitalization rate in January of this year, up to 2.1%, we saw a major decline to 0.6% in March. But again, in like late March, April, there was a surge back to 1.3 among adolescents, like hospitalization rates. And then what was worrying also was 1/3 of this admission actually needed intensive care monitoring. And 70% of these children, adolescents, actually had one underlying comorbid or medical condition. So what we think was probably this medical condition must have predisposed them to have the COVID infection in the first place, or to cause severe COVID illness. But what was more worrying was, like 30% of healthy adolescents also were seeing severe COVID-19 infection. So we'll come to this later, why, like this is happening. But this is, like this actually got all of the pediatricians worried in the US and also globally. So to understand the pandemic, like we also need to know how the SARS-CoV-2 enters, or why SARS-CoV or the COVID-19 has a plethora of symptoms. So because, like for the SARS-CoV to enter the host cell, it needs to have fusion with the ACE2 receptor, so the angiotensin converting enzyme 2 receptor, which is present everywhere in our system. That's why we are saying, like mostly, in the lung, type 2 pneumocytes, which actually produces surfactant, but it also present in the heart, the kidneys, the blood vessels, brain, everywhere, you name it. So you can actually see the plethora of, like symptoms we are actually seeing in COVID, mild COVID, and then severe COVID. So the summary of 3 meta-analysis actually showed that fever and cough were the most common symptoms reported in children. So in, like in the majority, so probably, like 50% and over. What they also found was, like there was a handful of, like 2,000 children from the Chinese children early on in the study, where they also found that, like adults, the distribution of symptoms was similar in kids too, like with rhinorrhea, myalgia, fatigue. Anosmia was not, like mentioned earlier, but the recent studies are actually saying, like anosmia is also mentioned in kids. But as I said, fever and cough seems to be the most common presenting symptoms. Again, most children remain asymptomatic, or with mild symptoms, what we have seen is children have fever, brief fever for a day, too, and they can probably have, instead of fatigue, they probably will have refusal to eat. Those are the things we see commonly in children. Again, when we look at the labs, most of the children don't end up having labs, but the children who get hospitalized or who are in the path to the, like severe or COVID infections tend to have labs, which, like usually the lymphocytes numbers can vary, but lymphopenia was mostly noted, which doesn't seem to have any prognostic value. But what we also found was inflammatory markers, which if elevated, seem to actually go in or tie in with severe COVID, as we all know that, like higher, inflammatory states are associated with progressive lung inflammation or systemic inflammation, and of which, like as I mentioned, CRP, and then white cell count can also be higher. These actually have prognostic value, or also can say that can tie with the severity of COVID illness. Let's see. So next, like when we look at lab imaging, as I said, like most of the children don't need any lab or, like labs or even chest imaging. Like in adults, we have seen that children who have severe COVID or who end up in the intensive care tend to have ARDS-like picture with bilateral consolidative opacities. And as I said, like the ACE2 receptors are usually present in the pneumocytes, which are used for producing surfactant. And when your surfactant depleted, you can have all these changes. Even in children who are not very symptomatic or even mild infections without oxygen desaturations, we actually have seen chest X-ray abnormalities. So the chest X-ray abnormalities can be there in children who are, like who will not, it does not say that, like they are going to definitely progress to severe infection. It just says that they have lung inflammation. And most of them will recover at this stage and will not progress further. So the next, coming to the special groups. So what they found was, like when they did a study of the JAMA network, actually had said like when they included 43,000 children with COVID-19 diagnosis from March 2020 to January 2021, the risk factors for hospitalization, which stood out was, like type 1 diabetes with a risk ratio of 4.6%. That means if I have type 1 diabetes, I am at 4.6% higher risk for contracting COVID or severe COVID. And the second was followed by obesity. And then the risk factors for severe COVID illness, again, like in type 1 diabetes, or if I have cardiac and or circulatory illnesses. In the less than 2-year-old, what we found was, I just have to adjust my screen. What we found was, BPD, prematurity, and then prematurity seems to be, and BPD seems to place the children at higher risk for hospitalizations and or severe COVID. So this again is like a pictorial graph just saying that type 1 diabetes and obesity, if you have these two risk factors or underlying medical conditions, you're at higher risk for one, getting COVID or having severe COVID infections. So then among the hospitalized children with COVID, as I mentioned earlier, that we found that 70% had an underlying medical condition. And the most common were, like asthma, being the most common underlying medical condition in 10%. So what I'm trying to say here is, like when children come to hospital for a COVID or a COVID related, hospitalization for a COVID related illness or, like unassociated, what they found was most of these kids have, or at least 10% of these kids have asthma. But having asthma per se does not predispose you to having severe COVID illness. They had an underlying diagnosis, but this did not, put them at risk for severe COVID. So then moving on to the next special group is, like Missy. So Missy is multi-system inflammatory syndrome in children. So here, Now, instead of the lung, the inflammation just being confined to the lung, now I have systemic inflammation. So the major organs being, like other than the lung being your heart, your GI system, and or the brain. So the case definition by CDC and WHO is like if you have presence of fever for relentless high-grade fever for more than 24 hours, along with elevated inflammatory markers and multi-organ dysfunction, more than two systems being involved, the suspicion of Missy should, or we need to make sure that this is this is Missy unless proven otherwise. And in India, we also need to make sure that there are not other diagnoses, the common ones being dengue and malaria, and then I was told scrub typhus too. The interesting thing with Missy is it does not have the temporal association with the acute COVID-19 infection is anywhere from 2 to 8 weeks. So if I'm at the far end of that time spectrum, so 8 weeks, many parents might even forget that their child had COVID unless the symptoms were severe. So the PCR, RT-PCR test usually will be negative, but then most of them will have the antibody positive titers for COVID. So this is how we know that there was they have been exposed to this infection earlier. Again, the common clinical features being cardiorespiratory involvement, and this Missy seems to affect this 8 to 12-year age group and not the younger ones. So how do we know that this is not, Kawasaki's? Because when it first came on, the question was, is it Kawasaki? And we all know that Kawasaki has, a higher predisposition in, Asian kids, and also following, any recent infections. So with Kawasaki, they'll have, most of the symptoms similar, but they also have predominant mucocutaneous symptoms, whereas COVID seems to have more cardiorespiratory symptom presentation. So again, this is a recent publication from February where they found the characteristics and outcomes of US children and adolescents with Missy and severe COVID. So they looked at 1,000 patients and they showed that 6 to 12, so the age group 6 to 12 years puts you at a higher risk, or a 1.5 times higher risk to have COVID versus the less than 5 years age group. And as I mentioned earlier, predominant cardiorespiratory symptoms. And then Missy has a higher risk of cardiac involvement versus a respiratory, and they have a higher inflammatory markers and slightly higher mortality rate compared to severe COVID. But what we also found with relation to Kawasaki's is, most of these kids who have coronary artery aneurysms it tends to resolve by the time they get discharged, suggesting that it's not an inflammation, but rather, a vasodilatation because of the severe illness. So most of them have shown that, the coronary artery aneurysms have resolved by the time they get discharged from the hospital. So in infants in less than 2 years, again, less than 12 months, again, the Missy can happen, but the manifestation seems to be less severe when compared to the 8 to 12-year-old age group. So the next, coming to my, my specialty. So when we heard about the pandemic, most of the, the pediatric pulmonologists and parents were extremely, and pediatricians were extremely worried because, I already have an underlying lung issue, and how am I going to, or my child going to react to this virus? So the European Respiratory Societies actually sent out a questionnaire to many different centers. So 94 centers responded with bringing the total of 945 children. So these are basically asthma clinics, any respiratory clinics taking care of children with asthma, cystic fibrosis, non-CF bronchiectasis, and other chronic respiratory conditions. So what they found was majority of the kids, especially in asthma, as I said, majority of them did not need treatment. And then the CF population, again, majority did. So there were 14 children identified, and then 10 actually did not need treatment. But what they found was children with chronic developmental disorders like BPD and other respiratory illness like with the neuromuscular illness, they all needed hospitalization or some form of respiratory support, either invasive or non-invasive. This just shows that, like the severe my underlying lung condition, the more severe the COVID infection or the way I handle it's going to be. And the other thing also is, like cystic fibrosis patients know that they need to be very careful. So they were probably maintaining or following all the COVID appropriate behaviors, and the similar thing with asthma too. So they found that, like social measures tend to help these kids to stay safe. So now just talking about the COVID treatments available, I'm not going to go into the details. Already Indian Academy of Pediatrics has very robust guidelines, which Dr. Gunasingh shared with me. But what we need to understand is, like there are different phases. The first is the viral response phase, where the virus is in my system, but I haven't started showing signs yet. This is the asymptomatic or the pre-symptomatic phase. So we have to be judicious here that, like this is the time that we should, like the virus is actively replicating. So there is no role for any medications other than, like a symptomatic treatment. And the second is when, like the host inflammatory response sets in. And then we have some medications which have been shown to be beneficial in this particular phase. So acute COVID-19 management in children is like any other illness where standard pediatric lower respiratory tract infections and ARDS management applies, and majority is all supportive care. We also found one study, or a couple of studies have actually mentioned there is a high risk, like 20% chance for a co-infection. So if you're thinking the clinical symptoms doesn't match or seems to be out of proportion to what the child with the COVID-19 should have, early bacterial antibacterial treatment should be instituted, especially in kids who are like in the intensive care or are needing escalating respiratory treatments. We usually don't go down the route of IVIG or IVIG unless it's Missy. And then we also consider prophylactic anticoagulation, because we know severe COVID and Missy kids have a very high proportion for thromboembolic disorders. And then in centers, like where they have ECMO, so if we think that the kid is not actually doing well or needing escalating treatment, they need to be transferred to a place where they have ECMO facilities. And as I mentioned earlier, like most of them, like will become better. They have, like will not progress into the severe COVID phase. And if at all, they will need supplemental oxygen to maintain the saturations above 92% or 92 to 95%. And if they need escalation of treatment, we usually say non-invasive, though we know, like aerosol risk is higher. If they are maintained in respiratory isolation, non-invasive ventilation is still the first step. And if they need intubation, it should be by a skilled practitioner. And again, as I said, because like aerosol dissemination of this virus, it should be by a skilled intensivist or an anesthetist. We don't have much literature on the effects of prone positioning or in children, but we still do this, like for ARDS, we still do this. So, like we can trial this if we think this would help the child. But as I mentioned earlier, it should be supportive care, early antibiotics, and then prophylactic anticoagulation, and to be in a center where ECMO is available. I'm not going to talk much about the rest of the treatments, because if you look at the recent WHO guidance, they don't have any literature, even in adults, on many of the treatments which have been kind of trialed or used. But the one thing which has stood out was steroids. So steroids has shown a benefit when, as I said, when the inflammatory state has set in. So that means we really need to be judicious in the timing of steroids, when to use it, how to use it, and how long to use it. So we typically use that for 7 to 10 days for children who need, like intensive care, or who need escalating oxygen requirements, or who saturations, kind of worsen. These are the kids we typically tend to use steroids, and usually for a period of 7 to 10 days. When I'm using it for 7 to 10 days, I don't have to worry about adrenal suppression or other common side effects which are seen with steroids. And what they found was, there was a mortality benefit both in critical illness and severe illness when corticosteroids are used at the right time. I think we talked about this. And again, like this is the IDSA randomized trials again, which actually showed one, like that the severity of illness can be made better, or the mortality benefit when we use steroids at the right time. I think I talked about this. So, like just to mention about remdesivir, like WHO basically has said, like it should be a special situations. The remdesivir usually acts by premature termination of the viral RNA transcription. Here, like in my practice, it has to get the approval from the ID specialist before they give remdesivir. It's not like part of regular protocols or treatments. I'm going to skip monoclonal antibodies, and I'm going to skip all this. So as I said, like remdesivir, like the WHO has come out saying that, like it doesn't make big differences. So it's a case by case basis. So now moving on to the next high risk groups, like maternal and neonatal morbidity in pregnant women with and without COVID-19 infection. So this study was done between March and October of 2020. In 18 countries, 43 institutions took part in the study. And then the inclusion criteria, any stage of pregnancy with and without COVID infection. So what they found was, like they had 700 pregnant women with COVID infection and nearly 1,500 pregnant women without COVID infection. What they found was overweight was seen in early pregnancy in pregnant women with COVID infection. But what was more alarming was women with COVID infections were at a higher risk at, like a risk of, like 22 times higher risk for maternal mortality just because of COVID. They also have higher incidence of preeclampsia, severe perinatal mortality needing NICU stay, neonatal deaths before discharge, preterm births, and severe neonatal morbidity leading to hypoxic ischemic encephalopathy, bronchopulmonary dysplasia, sepsis, and IVH. So basically, like it just shows that, like in pregnancy per se, like is a disadvantage, especially when it comes to lung function because of this gravid uterus. Your lung capacity is reduced. On top of that, if I were to have COVID infections, I'm going to be at a higher risk for severe COVID and maternal and neonatal morbidity and mortality. What they also found was COVID positive pregnant women, even if asymptomatic, still were at a higher risk for maternal morbidity. And then there was also a risk that the neonates were tested positive. C-section actually was associated with a higher chance of the neonate testing positive for COVID, but breastfeeding actually was not associated with the neonates being positive for COVID infection when the mother had COVID. So next, moving on to the breastfeeding. So what we have been recommending our mothers was that, like if the mother is clinically stable, then she should be allowed to continue to breastfeed, but mother should wash her hands, should wear a mask. We also say that, like if they can actually change their clothes prior to every feeding session, that would be ideal. If they have some other caregiver at home who can take care of the child between feeding sessions, that is very welcome, but many mothers might not have that luxury. If that's the case, what we suggest is, like to have the baby in the same room, but a well ventilated room, so that, like there is not so much of aerosol, spread of infection to the baby. So then now talking about, like how can we actually, like contain or, like curb this pandemic. So they did a study and they found that, like this was actually a model. It's actually not a study. What they found was almost 60% of transmission actually came from asymptomatic transmissions, which could be either, like in the pre-symptomatic phase or truly asymptomatic phase. So what this all reinforces is that even though, like we have, many of us had natural immunity, either because of vaccination or through natural infections, we continue to follow this COVID appropriate behaviors, because there are so many vulnerable who are probably left exposed if we don't follow these guidelines or measures. So that, like, brings us to the topic of universal masking, hand washing, and distancing. So initially, like when the start of the pandemic, the idea was it was all from droplet infections. So droplet means, like the larger size infection, larger size deposition. That means, like it's not going to travel in air far. That means, it's just going to stay, drop to the surfaces nearby. And then, like fomite transmission was thought to be one of the main reasons. But as we learned more about it, we now know that, like this airborne transmission is happening. Airborne means, like it has become an aerosol that's very small in size, that it suspended in air. It can travel, like longer. So that's why, like we say, by universal masking, the idea behind that is, like we are trying to curb the viral load. So when I say viral load, just to put, like given a simple example, if I have a 50 virus entering my system has a capacity to take care of it, like by mounting an adequate immune response. But if at the same time I'm exposed to, 5 lakh or 5 million viruses, my system is going to be overwhelmed. So just by having a mask, like if your nose actually is an effective filter. So the two functions of the nose being, one is, like it's filtration. The second is humidification. By filtration, I keep all the bacteria, viruses, and the substance which doesn't, or the viruses or bacteria which doesn't belong to my system, out of my system by having, like an effective nasal filter. The second is, like having the external, the second additional layer of mask. We can also reduce the amount of viral load or inoculum, because that's what also drives or triggers the severity of COVID. And then the second is, like the 6 feet we talked about is just for, like the droplet infections. But we know that, like aerosol transmission can happen. That's why we say to have well ventilated rooms or offices where, the airborne transmission is actually, like mitigated or reduced. I think we talked about this. I think I said this too. So, like there are actually many studies, like both in community level, state level, even like even a hair salon in one of the states, they actually have found that just by, this is all before, like the vaccination came into effect, by following simple general measures, we will be able to curtail or curb this infection from spreading or having local flare-ups. So now moving on to the current vaccines, like how is, there's a lot of myths about the COVID-19 vaccines. The two vaccines which we have in the United States are mRNA vaccines. So traditionally, vaccines are developed, like based on inactivated, like the bacterial or viral particles. But with mRNA vaccines, what we have been trying to do is we are actually trying to have that particular protein. So in this case, like we found that the binding and the neutralizing antibodies to spike protein. So that's the one, like which actually gives or offers protection. So we are trying to trick our system, or not trick, like tell the system that, like now I'm exposed to this small amounts of spike protein, and then I develop immune response to this spike protein. So what we have found, at least in like most of the studies, in like the two mRNA vaccines we have, is one is in like Pfizer and the other one is Moderna. So mostly they are 90% effective. So when I say 90% effective, when I give it to 100 people, 90% of them will have an immune response. So what we also found is, again, like this is all based on prediction models, is if we have a 90% effective vaccine, and if at least 50% of the population is covered, we can then have herd immunity. So what I actually mean by herd immunity is that means the threshold immunity where the the infection rates does not continue to rise, that we are still in the pandemic phase, because we are still seeing rise in infections, and also like in pockets where it's just having a surge. So we are still in the pandemic phase. For us to move into the endemic, or so most of the pandemics will eventually become epidemics. When I say epidemics, it's like like influenza viruses. It's an epidemic. Every season like we have a surge, and then like the rest of the time it is the same as the previous years. So this pandemic also will become epidemic, but for that to happen we need to have herd immunity, so which can be achieved by two. One is like natural infection, which like is not acceptable with so much of adverse outcomes and mortality. The second is vaccination. And many countries for many reasons like we cannot achieve this vaccination in countries like India. There is a shortage of vaccines, but in countries like US like we don't want to take vaccines because we are worried, because it's a new vaccine, nobody wants to take vaccines. So we are going to continue to see many of these infections or infection surges which happens. And the other question is about the different variants. What are these variants? So the variants just tells that there is like the virus is still in circulation. As I mentioned earlier, RNA viruses tend to mutate like crazy, and then the moment like they find a suitable host, they are going to mutate so that it becomes either extremely transmissible, as we saw with the Delta variant, which is currently in India, or it can just like be like not so bad. So the question which is lurking for the pediatricians then is like, now we are seeing an increasing spike in children. Is it because the virus is truly very highly transmissible, or is it something else? So from at least from the US data, what we could see is majority of like the older population, 65 years and above, have been like at least it had one vaccine, and many of them had actually had the second vaccine too. And we have rolled this down to up to 12 years now. So more and more the younger population are also affected. So the others which are now left out of the 0 to 12 years. So we will see infections, but not severe infections as we saw in the adult age group. And as I said, like FDA has just approved the vaccines for children up to 12 years of age. And then just to end my talk, I have to thank, like when this all first started, when we are hearing all the stories in India, like it was heartbreaking, because to see my people suffer, there was no oxygen, there was no beds. So we actually partnered with Yuvati, which is an NGO organization in Chennai, who actually was doing great work on mental health awareness in children and women before all this pandemic. So we partnered with them, and then the brainchild, like the brain behind all this was like Dr. Amulya Rao, who is one of my best friend, who got us all together to like help with creating a Facebook handle where we vetted all information about COVID, so we can have authentic, legit information on COVID, both in English and adults. And you can see all this like posters we created. It's not just about COVID, and like COVID and like pediatrics, and how like sleep issues, like general measures. And we also, what we did was like also like one of my other colleague, Sadhana, like my classmate from KMC, she did televisits, like she was talking to families, helping them like stay at home, monitored them, so that like we can give medications, because bed availability was like a huge problem. So if we can actually keep people at home and then give them medical advice or share our expertise, we can actually help people who truly need hospitalizations. And then a generous donation from, again, one of my classmates, where we printed nearly 50,000 posters. If you see in Chennai, every nook and corner has this poster this gentleman was viewing, like you don't need to read or write. It's all pictorial description of, like how you can keep yourself safe during this pandemic. And also a great shout out to Sharanya Bakiraj, who's like a social reformist, social activist, who helped us with like putting out these posters, getting people like oxygen supplies. I mean, Yuvati actually did that. So they did medicine kits. They actually provided meals for families who are completely quarantined. They found beds. We actually kept few patients at home on oxygen concentrators, and most of them actually, like got better, or when they needed, we also found beds for them in the hospital. And with that, I would like to end my talk. If there are any questions, I'm happy to take at the end. And again, thanks for this lovely opportunity to meet you all through this forum. Thank you. Back to you, Dr. Gunasingh. I'm just going to stop sharing.
Thank you, Dr.